Hello all, thank you very much for attending our final webinar of this series, continuing education series by Medmont. I would like to thank, of course, Randy Kojima, who is going to be moderating this event. I'd also like to thank Dr. Metapors Rameston and also Nikki Sore. I would also like to say thank you to our co-sponsors. That would be our good friends from Nidec USA, iVinci from the Netherlands, number 7 contact lenses from the UK, MedCornea from Russia, CooperVision Soflex from Israel, of course, Belgian Optical Supply, who is with us now, Nikki, and ConLens, of course, Meta, and Belosa from Austria. Thank you very much again for all attending, and over to you, Randy. I appreciate everything that you're doing for us as well, too.
Well, thank you everybody for logging in to be with us today. And on behalf of myself and the panel and Medmont, we really appreciate you being with us. And we hope this session will be dynamic and that we'll be able to cover a wide range of topics. Now, this session has been put together or basically it's been constructed based on questions that all of you have asked in the previous sessions over the past month. So we'll begin with the first question. And that was, how does the patient position fixation change to capture a visual or geometric axis capture? So is there a difference in how you manipulate patient position or patient fixation? How do you do the two different captures? So Meta, would you get us started with your thoughts on how these two very different types of captures are taken?
So for the visual axis capture, this is what we would normally consider as the normal capture, where the patient fixates on the target in the topographer. For the geometric capture, you will have to instruct the patient to change fixation a little bit. It must be ring by ring until the placido rings are centered well in the cornea. It would probably often be just 1 or 2 rings nasally, probably. So this will allow you to do the geometric capture.
Great, thank you, Meta. So as far as patient position goes, the position of the nose, the position of the chin, whether it's straight on or to the right or left, does that change at all when you're doing a visual axis or a geometric capture?
No matter.
Speaking purely about head position, not eye position.
I would prefer the patient to have the most normal position, but sometimes we need to adjust a little bit because of the nose, or if someone has a very big bones in the top of over the eye, so as they must be sitting as normal as possible when you do the capture.
The deep set eye is a challenge with any topography, isn't it? And moving the nose away from the instrument is always helpful for any capture, whether it's visual axis or geometric, correct?
Yes, agree.
Yeah. You'll often have to, with the Medmont, often have to put the chin a bit forward as well to tilt the head slightly backwards.
Excellent. Yeah, that's a good point. So as Meta said, just in case that it isn't 100% clear, and this is a very difficult concept for many, it's visual axis is the normal position of fixation. The patient is just looking right down the axis of the instrument at that central ring, just as Meta described. However, to take a geometric capture, you're trying to move the placido off the nasal side. You're trying to better center it laterally. So as Meta said, you want to move the fixation 1, 2, maybe a few rings more toward the nasal side. So the patient is looking into the nose to move the placido out. And that's the major difference between the visual axis capture and geometric. So visual axis, right down the center, right at that central ring. Geometric, we're looking slightly in to push the placido reflection so it's geometrically centered to the eye. Meta, your thoughts on using this? How often do you use a visual axis and geometric capture, and for what applications do you use these two?
I would always begin with doing the visual axis capture, and normally I will use the geometric axis capture in those cases where I find there seems to be a huge decentration of the placido rings. But the system and the topographer calculates the image based on a geometric capture. So the topographer thinks that we are doing a geometric capture every time. So if the capture is too decentered doing the visual axis capture, there might be induced some errors, mainly in the periphery, and we want to avoid that, of course. If we do Orthok, it might it can give us some problems when we do the subtractive maps later on.
Boy, it's such a good point that if we're trying to build a contact lens that we want centered, why would we want our placido skewed toward the nasal side? It makes perfect sense. Nikki, your thoughts on whether you use visual axis and geometric? Is this something you include in your work?
Well, visual axis is a standard capture mode, but as you said, for contact lenses, it's important that you have a centered measurement, because it's there where you're designing your lens or fitting your lens, and you want your lens to be as centered as possible. So the geometric axis is very important to capture for designing your contact lens.
I asked John Mountford this question, and John Mountford I consider as the godfather of topography. He's certainly my mentor in topography, and he said the visual axis is what the patient looks through. So of course it matters a great deal. But as we all discussed, if we're trying to build a rigid contact lens, it makes sense to use the topography that's geometrically centered. Well, thanks everybody. Here's another question that comes up with great frequency all around the world. During topography capture, do you use eye drops routinely? Do you always do that in dry eye patients, as an example? So Nikki, could you take us through your thoughts related to using preservative-free artificial tear or any kind of eye drop?
Yes, thank you, Randy. It's a question as a distributor and a trainer we get a lot. So what we hear in the market is some people always use eye drops. Sometimes people only use eye drops in dry eye. Personally, I'm in favor of only using drops in a dry eye because it tells a lot about the eye itself and the tear quality. If you're just taking a measurement without eye drops, you should have a good quality image. If you're not having a good quality image at that point, it tells you that there's an issue with the tear film quality, because right before you take the capture, you ask the patient to blink. So you have a nice surface to take the measurement. So while not using an eye drop, I already have an idea about the tear quality. If you're using, if you're in favor of using a tear film drop or a drop to stabilize the tear film, I would use a mild drop, a very fluid drop, just to stabilize the film, not excessively using eye drops. Perhaps wait a couple of minutes for the volume of liquid to normalize into the eye, because otherwise you'll have a lot of deformation also in the tear film. Watch out also for additional tear meniscus below, which will influence perhaps the image as well. So that's from my end, my perspective on using eye drops. But I know there are people who are always using eye drops. I don't know, Meta, you?
Meta, please, your perspective.
Yeah, but I agree very much with Nikki. I do the same thing. I always start to do the capture without the eye drops, and then I use eye drops if needed, but only if the outcome of the topography without the eye drops is not sufficient. But also I like the idea of having this evaluation of the tear film already at the first capture. So only
guys, sorry, Mette.
No, I'm on.
I'm curious what your thoughts are related to scarring. Now, if you've got a patient with a central cone that is fairly scarred and the ring reflection is similar to a dry eye patient where it won't smooth out, I'm curious of your thoughts, how you might address that, especially when it's those central rings. Nikki, your thoughts about scarring?
In case of scarring or very hard to capture eyes, we often use a daily disposable lens, low power, as you mentioned during one of the sessions, and this is also something we do. That's in case of very hard eyes. I haven't really used drops to resolve this issue. So I don't know
Mette?
if you, Mette?
Yeah, but I think it's a very good idea with the soft, thin lens that will at least give us a topography we can go on with. But of course, keep in mind that it might change the image a tiny little bit.
Makes sense. Well, thanks, guys. One of the questions that came up is, what is the best value to use, E, E squared, P, or Q, and what is the difference between them? Now, these values are used to attempt to understand the eye from the center to the periphery, and each one is meant to describe that corneal shape or that change from center to limbus, let's say. But why would we use one or the other? And this is an excellent article by Helen Swarbrick, written in the very early days of our kind of push in orthokeratology. So if you want to have an understanding of the difference between E, P, and Q, this is the article to read, Helen Swarbrick. Now, eccentricity describes how the eye will change from the center here or here, and how it flattens as you go toward the periphery. So as we move our point of measure from center to periphery, of course, we know the cornea flattens at a fairly significant rate, and that rate is determined by the eccentricity value. So the higher the change, the more the cornea flattens from center to periphery, the higher the eccentricity becomes. Now, a normal, non-surgical, disease-free eye will generally be a prolate shape, steepest in the center, flattest toward the periphery. If there's anybody on this webinar that has a perfectly spherical cornea, if you have ever seen a perfectly spherical cornea with a zero eccentricity, I would pay money to see that eye. I would love to see that topography. At least in the thousands of patients I've seen, I've never seen one that's perfectly spherical. But if we go the opposite direction to the prolate, of course, we have the oblate, where it's flattest in the center, steepest toward the periphery. And eccentricity wasn't designed to describe the oblate eye. So that's a limitation of using E-value. So these are the various formulas, not that anybody is really interested in that, but what is valuable is in Helen Swarbrick's article, she showed to us where sphere lies. So for eccentricity, a perfectly spherical eye would be a zero eccentricity, and the E-value can describe the cornea as being a degree of or a magnitude of prolate. E squared can describe the prolate eye as well as the oblate eye, with zero being a sphere. So this is helpful because if you're trying to appreciate how oblate is a post-LASIK patient, you can use the E squared value. Now the P value uses a factor of 1 as being the sphere, and an oblate eye would be greater than 1, and a prolate eye would be less than 1. So it's opposite to what we might do with the E squared value. Then finally, Q, or asphericity, looks at 0 being the sphere, and a oblate eye is going up in value, and a prolate eye is going negative. So to give you some idea of what's normal, and we've always known that eccentricity, or for many, many decades, eccentricity was known to be normal at 0.5. P-value is known to be middle of the bell curve at 0.75, and Q-value, or asphericity, at negative 0.25. So that gives you some idea of where the eyes will lie in a normative range. Now, when evaluating an oblate corneal surface, like a post-LASIK patient, one of the questions was, how can E squared be a negative value? How can a squared value be negative? And the formula, again, going back to this formula, is E squared is based on 1 minus A squared over, B squared over A squared. So if B is larger than A, that's when we're likely to see an oblate eye. So in the formula for topography, at least, it is possible to have an E squared, a negative E squared value. And as we discussed in the previous session, if the negative E squared value is greater than 0.25, that's a pretty oblate eye. So that's one of the considerations that you might make related to fitting reverse geometry lenses. Okay, and our next question is, in disease detection, does the 10 diopter axial scale range of power distribution apply to the composite eye capture? And as you may recall, what we discussed was, when you have an eye like this and you're trying to question, is this a droopy apex or is this a early keratoconic, we would look at the scale range. When the distribution of power is greater than 10 diopters, then that might be indicative of an abnormal eye. This eye is around 7 diopters. But a composite map includes much more peripheral cornea. So, Nikki, can you take us through this very good question? Can we still use 10 diopters of scale range in a topography that's giving us so much more peripheral cornea?
You will often see that the 10 diopter scale, it's still close, but in composite topography, but you might slightly go over it. And this is just due to the fact that you get so much more data in that periphery, which is much more flatter than the center part. So have a look at your scale, but it's not because it's slightly over the 10 diopters that it's a diseased eye. Look at your distribution, look at your normal map, but even if you're using a composite map, you'll end up often around the 10 diopters, sometimes slightly over, but if it's way over, it's also an indication that it's a diseased eye.
So Nikki, your thoughts might be, we would look at the radii of the central cornea and then maybe 5 millimeters out rather than going all the way out to the limbus. Is that where we might be looking at the power distribution?
Yeah, that's correct.
Okay, so just not going out too far. That's basically what we're trying to avoid, huh?
Yeah, okay. Indeed.
Another question is, how often do you calibrate your E300 Corneal Topographer? And I can tell you that we're super guilty at the university of not doing this regularly. Nikki, again, maybe I could rely on you. What is recommended for this? What do you do?
So based on the manual of Medmont, it's recommended to do it on a monthly basis. What I recommend to my customers is start with a monthly basis. We all know it's something that is overlooked a lot. I recommend to put it in your agenda once a month as a reoccurring appointment. That way you'll never forget it. If you see after a while that the measurements are stable, you could do it perhaps on a 2-monthly basis. But also, if you see month after month, there is a big change, because, for example, if your Medmont is mounted on a unit which is moving a lot, it can happen that there is much more deviation than normal. I would recommend to perhaps look at a bi-weekly calibration. So get a bit of experience where with your Medmont, how much differentiation is there or difference after each calibration there is. Medmont will help you nowadays also after 6 months only, but it will remind you that your calibration has expired. So this is perhaps a helpful thing to keep in mind. And one thing I would like to point your attention to as well is be careful with the calibration ball, because it's an essential part of your Medmont instrument. From the moment there are dents or scratches on it, it's lost then, and you'll have to reorder a new one. So this is also something I would like to point out.
So Nikki, you're telling me not to be lazy and to do this every month. How long does it take to do a calibration for those who don't have a Medmont?
It's a very quick thing to do. You just take 5 measurements. It's a very easy, intuitive way Medmont have made this up. You just go through 5 measurements, and then you have the option for a quick calibration. It takes a minute or 2 to go through the calibration if you do it on a regular basis, and that's all it takes. So it's something that is done very quickly.
Okay, I'll stop being so lazy then.
Yeah, put it in your agenda.
Next question is the pupil measurement reliable in photopic and scotopic conditions? And from a previous session, we discussed how we might do topography both with the lights on and with the lights off to understand the range of pupil size, especially as it relates to any kind of presbyopic contact lens fitting when we may not have a really large optic zone size. So Meta, can you give us some perspective on, is this Medmont topographer accurate for giving us an appreciation of the pupil?
Well, I will recommend to yes do these captures both with light on and light off, which will give us some idea of the extremes of the pupil size. However, I will be more rely on the measurement with the light off than the light on, because the amount of light in the different examinations rooms can vary a lot, and that of course will affect the size of the pupil. So I will likely think that in real light, like the pupil might tend to be a bit smaller in reality than what we see in the measurement.
Meta, how do you use Medmont's pupil diameter? How is this used in your practice?
So what I use it for, or how I? Yes. Well, I will use it for doing multifocal lenses to find out how large a zone size I want, but also to when I'm designing lenses, how large or small can I make the back optic zone diameter to avoid that that the lens will create some aberrations in the visual field. So, but also especially in Orthok to allow us to put as much plus into the sensor without making too many aberrations to the vision.
Yeah, I think it's so valuable related to the multifocal optics. I couldn't agree more. Nikki, your thoughts? Do you use the pupil diameter often or routinely? What are your thoughts?
I follow Meta on this. One additional thing, it's also been in the sessions as well, is very valuable when you're doing topography on top of a multifocal lens, where you can see the add power in the lens, and then you can see if it's really centered over the pupil or not. And this will give also a good indication if you're having a reliable fit or will achieve good visual quality with that multifocal lens, or if you'll have to change to another lens, for example.
Yeah, thank you guys. Here's our next question. How many days will it take for the cornea to normalize following contact lens wear? I love this question. It's something that has a great concern in the Ortho-K patient, where very often we get patients in Vancouver here, where we're right on the Pacific Ocean. We get a lot of Asian patients, and they may come in having worn Ortho-K lenses, but we have no data at all on their lens. We don't have any history. We don't know what to do. If they need a new lens, we don't know how to modify what they have. So how do we address this when we don't have any topography and we know the cornea is molded? So Nikki, your thoughts on how long does it take before we can get a reliable topography post-wear of any contact lens?
Yeah. It's a good question, but also a difficult question, because there is no real answer to this, because it's dependent, first of all, on the type of lens that was worn, how much molding was there, and not only from Ortho-K, but you can have it from soft lenses, you can have it from RGP lenses. Also, the cornea itself and the rigidity of the cornea, the characteristics of the cornea play a big role in that. On average, I would say 6 weeks. What we see often that patients are very reluctant to take out their lenses for 6 weeks. So we often start at 2-3 weeks, and we take a second capture after 2-3 weeks and see if there's still a lot of change. And we do that with the comparison map of the compare function in Medmont. Often it goes longer than those 2-3 weeks, but at least some patients they have seen there's still change, so they accept it more than just saying you have to leave your lenses out for 6 weeks directly. It can even end up changing over a course of several months and even up to a year. So there is no distinct answer, just in my opinion, measure until you have 2 times the same measurement, and then you know you're back at baseline or should be back at baseline. That's my opinion on this. I don't know, Mette, if you have anything else.
No, if we are so lucky sometimes that the practitioner who is working on this patient has some old data, for example, like some old K readings or just something that we can compare with the results, that is of course helpful. But yes, there's nothing else to do than just to wait until you can do 2 similar captures with some days between. But you really can get surprised on how long time it can take before the cornea is normal.
I added the slides. Yeah, this was a patient who inversed a right and left rigid lens, and it took nearly about 3 months before I had quite a stable measurement. So this person came back several times for measurements, but as long as you're seeing massive changes, it doesn't make sense to start fitting a lens, because you'll end up doing refits and losing time and also money. So it's better to wait to have a stable result in your cornea before attempting to start a new fit.
Makes perfect sense. Nikki, was this what you were saying, that to do a subtraction map
Yes.
between 2 periods? Could you take us through how the subtraction map works and how you would use it to verify the cornea is stable?
So you can use this for various reasons. for example, to monitor if the cornea is still changing after contact lens removal, but you can also do this to monitor keratoconus changes, post-refractive, things like that. So it's not only just for monitoring post-lens wear. And you just select 2 maps, and in Medmont you have I guess it's an analysis tab that you have the compare function, and you just select the 2 maps you want to compare by using the control function, and then hits the button, and Medmont will automatically make the calculation and the difference between the 2 maps. You can do that in both axial maps, tangential maps, refractive maps. So Medmont lets you do a lot of different subtractive maps on this. One point I want to make is also look at your scale, because depending on what you're looking at, down below you have the option to change the scale, and sometimes you need to make a different or use a different scale to have some more detail in your map, and that's what is Randy pointing out below. So, and this
That's
was
a very
also
good point.
addressed. Yeah, that was addressed during one of the sessions as well.
That's a very good point. I mean, here a plus 10 to minus 10 scale shows very obviously that there are changes this cornea is going through. But if it were small changes and not large like these ones, we would need a tighter scale. So it's a very good point, Nikki. I had a pair of sisters that I didn't fit. They were fit at 16 years ago, and then they came to me because they were struggling as adults with their vision, especially at night when they were driving. So they had worn Ortho-K since they were kids, but now the aberrations are beginning to bother them, and so they needed a refit, and I didn't have any data. And we did something like this that Nikki was recommending from a month to month, and we would compare last month to this month and see if there was a difference. If it was green, then we knew that the eye wasn't moving, at least between those 2 visits. If the eye is showing yellow, as Nikki is shown here, or blue, that eye is still moving. And in both those cases, it took 8 months for the one sister and 11 months for the other sister before the eye took on a normal shape and before we were seeing green on the subtractive map between visits. So that was a long time, almost a year for those eyes to normalize. And I think as the group is communicating, it's really difficult to say from one patient to the next the length of time that it's going to be for normalization. It's really hard to define. Now, a great question is, could we use the height map or some type of sagittal depth to fit soft lenses constructed based on sagittal depth? And boy, what a cool question, because we do this so often with scleral. We do this with all of our rigid lenses. Can we do this with soft lenses? Nikki, tell us your thoughts.
So indeed, we see new designs coming out on soft lenses who are based on sagittal depth. And for Medmont, the option is yes, because Medmont lets you calculate the different ways, the sagittal depth for the cornea. So one thing to point out is talk to your lab and find out at what chord diameter you need the sagittal height to be determined for that type of contact lens you want to fit. Medmont offers you the option to go to the details option in analysis. You click on that button, and then you can do that with one map or even several maps. And Medmont will give you the weighted average height at the chord diameter that you are indicated. And this is limited to normally the diameter of measurement. So as long as you have data, up to 9 or 10 millimeters of data, you will be able to have the value of the weighted average height. If that's not enough, if you need data for your contact lens, which is for soft lenses often 14, 15 millimeters, you'll need the the estimated height chord function, which is in the attributes menu, and there you can just type in or select the diameter you want, and then Medmont will calculate the estimated height based on 3 different axes. So This is important to know at what diameter you need the data from for your contact lens, and then you can use the data from your Medmont to calculate your soft lens.
So you're seeing a shift in soft lens labeling now. Nikki, you were saying that some of the soft lenses are labeling their lens according to sagittal depth?
I've seen some of them, not much, not in the major brands, but some specialty lenses start to label. They still use the BC, what we are comfortable with and what we're common with, but you start to see also labeling of sagittal heights in soft lenses as well.
There's been some great work by Afe, Vanderwerp, and colleagues to measure sagittal depth of the eye and compare that to soft lens sag. So I think that's really exciting that we're taking soft lenses in a much more mathematical direction for lens construction. I really love to hear that you're seeing custom lenses being built based on sagittal depth. That's exciting. Now, next question, what add power has benefits for myopia control in kids? And we discussed along the way how we might use the Medmont topographer to have an appreciation of the power distribution within the eye. So we would focus here on the pupil, the dotted red, and determine the radius of change at the center, the power change at the apex or visual axis, and then the difference from that point to the pupil margin. In this case, this patient has a 3.62 diopter add. So Meta, for myopia control, we have Orthok, we have soft lenses, even glasses are used today for myopia control. What plus should we be using within the optic space that we have to create good myopia control?
It's a very good question, and the adequate amount of plus has been discussed as long as myopia management has taken place. There's a lot of different opinions on this subject, but what we know is that we cannot have too much plus in the periphery. So the short answer is as much as possible. The great thing about the Medmont is, like we can see here in the slide, that you can actually see how much plus is distributed within the pupil area. So that is that helps us to know if the plus really gets into the vision and has an effect.
Meta, if we were to provide this particular treatment to a patient and the aberrations were too high, if the patient visually wasn't getting good quality of vision, then what? And let's presume it's Orthok, or let's presume we've given a soft lens to a myopia control patient and we had a 3.5 diopter add, aberrations too high, patient can't manage it, then what do you do?
It's a balance, because yes, we want as much plus as possible in there, but yes, it also can give some problems, add some problems to the vision, and those problems tends to be worse the older the patient is. But there are different options. Of course, you can choose between different products, like you can use a soft lens myopia control lens, or you can do Orthok. So there's it's possible to change the treatment. But if it's Orthok and we have this problem, I would try to make the treatment zone a little bit larger to see if this could solve the problem and still keep the myopia controlled.
Yeah, just finding that balance of the right treatment zone size with enough aberration to slow down the eye growth.
Yes.
Yeah, that makes good sense.
But it can be a problem if the patient has very large pupils. Sometimes it can be a tough problem, yes.
And we certainly see that in the adults, don't we? That when we do Ortho-K on an adult with a big pupil, the aberrations are often too much to manage.
Yes, and especially for driving at nights and things like that, which children hopefully doesn't.
This study kind of works to answer this question that was published in the Journal of Ophthalmology, looking at 130 myopic children. And in their findings, they found that if there was a big power shift in the earliest days of the treatment, so at month 1, month 3, and so on, that the bigger this power shift from the foveal change to the peripheral corneal change, the bigger the, let's call it ad, or the higher the spherical aberration, the better the myopia control. If the power shift in the earliest evaluations showed very little shift between the centermost minus and the pupil border, then that might be predictive that the myopia controlling effect may not be as strong. So the more power shift that you can create, the bigger the ad power, the better it is. And as Meta said, that if we push too much and the patient can't visually handle it, then we have to back it off somehow so that the aberrations are still there to slow down eye growth, but that the aberrations aren't so high that it hinders visual quality. Now, along the lines of Ortho-K, this practitioner wrote in, I was taught that the refractive subtractive map was preferable to the axial. What is the difference? So Meta, can you help us out here on this question?
Yes, the axial map is based on the corneal power in relation to the visual axis. And the refractive map is based on the corneal power point by point, so in any specific point. The 2 points is really very similar. So practically, it doesn't make a big difference which one is used. If we should look at the differences, the axial might overestimate the treatment zone a tiny little bit, where the refractive map shows the real or more ideal treatment zone. But again, it's very, very little difference. Personally, I always use the axial map for power evaluation.
And I couldn't agree more. I started by using all 3 of them, and now I've basically dropped the refractive power map just for the axial, just like you, Meta. You know, here when we look at an axial subtraction, here's before Ortho-K, here's after Ortho-K, here's the difference. And just, if you can, remember what this blue treatment zone looks like. And we'll compare that to the refractive power map. One thing that we might draw your attention to is, the astigmatism and its appearance. You notice with the rule cornea, you notice a fairly apical astigmatism. The second map that we often use, and a lot of practitioners actually rely on this more than anything else, and I feel that's a mistake. I think that we should use all of the maps, but here you notice in the tangential map, it becomes very obvious where that reservoir is, where that pull force on the epithelium is. Then this map tells us about lens position. Lastly, refractive map, you notice the blue treatment zone looks very similar to that axial map, as Meta said. What's significantly different is the appearance within the pupil, comparing before and after. It's very difficult to appreciate the astigmatic shift and how you've altered that radii that may contribute to vision and power. So when you compare, here's your axial, here's your refractive. Clearly the tangential is very different from both. But if you look at the subtractive side, as Meta said, they're virtually identical. So for axial, you understand the refractive change, you understand the astigmatic effects, and then you understand the treatment zone position. With the refractive power map, you also understand the refractive change, you also understand the treatment zone position, but you have a better understanding of the treatment zone size. Now, Nikki, your thoughts about using axial versus tangential versus refractive? Do you rely on one specifically? Do you use all three? Share with us your thoughts.
I do the same as Meta. I use the axial map, the tangential map, but I hardly ever use the refractive map. In my opinion, the axial map and the tangential maps tells me nearly everything what I need to know, so I won't get any additional or real additional information from the refractive map.
Meta, do you rely on the tangential over the axial over the tangential, equal? What are your thoughts about using these in ortho-K or refractive surgery?
It depends what information it is we look after, because yes, the axial map only tells us about the refractive outcome, but certainly for evaluation of the centration and the whole fit of the lens, how it affects the eye, is definitely I would look at the tangential. The tangential is also able to tell us if this ring, as we see as a red ring in the tangential map, is like a circle. It's very important if we are fitting myopia control that this ring is present all the way around. Because if it doesn't, if we only have like 2 half circles, we might not create this like, let's say, vacuum that we want under the lens to create the stability of the myopia management. So
yeah, thank you for that perspective. I think you guys are right. We could use all three, and for that listener that felt that the refractive has value, you're absolutely right. It doesn't. You don't need to drop it from your repertoire of analyses. If you want to just focus on two, you may not be missing that much by using just axial and tangential. This was more of a statement rather than a question, but I thought this was a really good point that would be worth us discussing. As an ortho-K fitter, I can say that axial power change in the center is surely correlating with the amount of refraction corrected, but they are not the same number, at least in some designs. You can never get away without actually checking visual acuity. So a great comment that I thought was worth discussing. Meta, could you provide some of your perspective on this one?
Yeah, I totally agree. I always recommend to do both visual acuity check and refraction, both with and without lenses at any follow-up visit in Ortho-K. The subtractive map gives a very good and accurate measurement, which certainly correlate with the real outcome. But because the cornea is not completely spherical, or there will be power variations within the map, and due to that, it's very important to do the power and visual acuity, or the refraction and visual acuity also, and putting those data together will also help us to know if everything is all right, because if our refraction tells us something completely different than the topography, we know we have to look carefully for because then something is not correct.
Makes sense. Here's an example where after one night, if we were to click our cursor right on the center, this patient is showing a 1.56 diopter refractive change. So using an axial or refractive power map, using that central power shift should give us a very accurate understanding of this patient's true shift in refraction. Now, if we were to do a autorefraction on this patient, the autorefractors tend to have a large entrance pupil. So there's a lot of aberration that the patient may be picking up, and the visual system interprets that as the need for more minus or more cylinder. So the reason why we might suggest using the axial central power change in the early days of Ortho-K is because refractively the patients will tend to want to, let's call it, eat up the minus. So you may find that the axial visual axis change, it gives you a really good idea of if you need to push more or less power. And then after 9 nights, you notice that pupil filling in significantly, and it really alters the whole corneal surface. As Mette described, we're going to smooth out and sphericalize that cornea. And that axial power change should become 1-to-1 with the refractive change after full effect, which we know is 7 to 10 days. So we've got to give it a little bit of time to have those two come to an agreement. Now, this work by Ahmed Alabri and Helen Swarbrick in the early days of Ortho-K showed us that Ortho-K full effect is 7 to 10 days. So if we're trying to understand what's going on after night 1 or night 4, we really don't have the full picture. It's helpful to wait out for full effect so that we have a much better understanding of the over-refraction, if any, the vision, everything that Mette had described for us. So I think this study is one that any new orthokeratologist really needs to appreciate, because it pushes you to wait out your effect. If you're not sure about what's going on, waiting out full effect really makes things much clearer. Is it an ideal outcome, or is it something that we need to modify? Did the effect not come out the way we desired it to? This was a great question. What range of astigmatism correction is possible with orthokeratology? And I'm super interested in Mette and Nikki's thoughts on this question. Mette, could I start with you? Give us your thoughts about astigmatism and Ortho-K.
This is a question I have been asked very many times, along with the question of how much power can you change in Ortho-K treatment. And the answer is you cannot put a specific number of diopters to answer this, because there's different factors that will affect what is possible. And this goes to the how flat or steep are the cornea. You can change more, correct more minors on a steep cornea than you can on a flat cornea. And it also depends a lot of the relationship between the refraction and the corneal astigmatism. If the astigmatism from the refraction is the same as on the cornea, this is the best. You probably have the best success rate on this. If the astigmatism is higher or lower than the refraction, it is possible to design an Ortho-K lens with a toric back surface to actually change the cornea into be more or less toric than it was before. For that, I would always recommend to begin with the normal spherical Ortho-K, and then after that has like settled, you can redesign based on the residual astigmatism. It can also have a huge effect if the astigmatism is combined with a spherical power or not. So the success rate would be higher if you have like a -3 with 2 diopters of astigmatism than if you have like only a -0.5 with 2 diopters of astigmatism. So there's a lot of factors that matters. But yeah, as a rule of thumb, if the astigmatism is higher than 2, or if the astigmatism do not correlate with the corneal astigmatism, I would recommend to ask your lab case by case.
Mette, I love the idea that we are moving in a very customized manner for astigmatism. You had mentioned using a toric in the optic zone, so different hydraulic powers across the two meridians. I think that's so exciting that that's the next direction that we might follow in Ortho-K. You know, Mette brought up a good point that we have to appreciate that we have different eye shapes and different relationships with the refractive sill. Clearly, our apical astigmatisms are much easier to manage in Ortho-K, that our limbus to limbus is tougher. So that's a factor. It's not just how much astigmatism the patient may have, but it's the shape of that astigmatism and how easy or difficult it is to push out of the way. The against the rule astigmatism offers some challenges in terms of centration, but refractively, I don't know if it's as much of a challenge as the centration might be. Certainly, if we neutralize the against the rule and we also have lenticular coming through, then that's a problem. Now you'll notice here in this Ortho-K on this apical astigmat, we did a really good job of sphericalizing the cornea, of pushing the astigmatism out of the way. But in this limbus to limbus case, we've basically left all of the patient's cylinder there. So there are times, as Mette described, that we're going to be able to move it out, and there are going to be times when we may not do much to alter that astigmatism. And clearly, the landing has to be altered for each eye to ensure that we have that 360 degrees of alignment. Mette, your highest corneal or refractive astigmatism that you've been able to fit in Ortho-K? What is, just give us an anecdotal, one patient was as high as?
I think we are maybe around 4 diopters of astigmatism.
Wow, that's awesome. That's an amazing amount. Nikki, in your findings?
I'm not a full-time fitter, so I personally don't fit a lot of lenses myself. I've seen cases of 4 diopters and higher as well, but then you're looking at custom Ortho-K lenses. You'll not do that with your off-the-shelf Ortho-K standard design. You'll need toric peripheries. You also have corneas which are standard steeper with the flatter corneas. You won't achieve that much cylinder correction. So it's dependent on various factors, of course.
I feel like I do a decent job of myopic Ortho-K. I don't feel like I do a great job with astigmatic Ortho-K. I don't feel it's as predictive as it is with myopic. So case by case, as the team described, I think that's the way we need to approach astigmatism in Ortho-K. Another question, and related to Ortho-K, and I thought this was kind of a cool topic for discussion. Would you create a multifocal shape for presbyopia with Ortho-K treatment? Wow, is this possible? Mette, here we have our myopia controlling topography, where we go from most minus to least minus or most plus in the periphery. One might presume that this is like a multifocal contact lens. Can this work?
It is a very logical and good question, because what we see of, like you just showed on the other slide, that the
Sure.
power distribution pushes a lot of plus into the periphery of the pupil. We would think that this would work the same way as a center distance multifocal lens. But it is my experience that it doesn't. Ortho-K patients, they have basically the same demand for additional correction when presbyopic. Though we can see that it might add a little bit of addition for them, so they might be able to wait a little longer until they get really presbyopic to begin to have additional help. And of course, it should also be mentioned that there are presbyopic Ortho-K designs in the market, though with various success rate as far as I am familiar with. Yes, but it's something that we would really love to have to do better in the future.
Yeah, certainly it's an area that could be explored more. As you suggested, there's been plenty of cases that have been presented at conferences and symposia that have suggested we can do this. I wonder if it's a case-by-case basis. As we know, in myopia control, we want to give the kids the small treatment zone to have the big plus power shift and the high aberrations that will slow down eye growth. Whereas with the large treatment zone, we have a lower plus power shift, we have a lower amount of aberration. So if we're trying to give a patient a high ad within the pupil, we're increasing the aberration. So while we might provide better multifocality, are we increasing the high order aberration such that the two are kind of neutralizing each other and we don't have a really great visual gain? Anyway, that was one consideration, but an exciting area certainly for orthokeratology. This was a question: when measuring the sagittal differential of the flat and steep meridian, what chord diameter do you use? And here you see a slide that we presented previously where we measured the flat, we measured the steep, we found the difference was 33 microns between those two meridians, and we suggested that around 30 microns or greater, that's where you would use a toric rigid contact lens, a toric Ortho-K lens, anything corneal and rigid, that is the threshold that appears to benefit from a toric. So what chord diameter should we be using for this measure? Nikki, could you give us your thoughts on how we should approach this?
Of course, it all depends on the lens design and the lens diameter you're using. So perhaps a good idea is to ask your lab if they can provide you with their suggestion at what diameter you should be taking that measurement. But on average, we could say take half to 1 millimeter less than the lens diameter you're using. So it all depends where your lens in the end is landing on the cornea. So if you're having a large lens with a small optical zone, that will be a totally different situation than a large lens with a large optic zone. So look at the lens design and where it's landing on the cornea.
I think that's such a good point, is we often think about the lens diameter, but Nikki, as you said, we want the chord of landing. We want, where does it touch itself down on the eye surface? So it makes sense to use that point of greatest bearing, and that's excellent recommendation for fitting rigid lenses and using sagittal depth. Along the lines of sagittal depth, can we measure the sag differential at 10 millimeters instead of at 8 millimeters? In the work that we shared in previous webinars, it was all based on 8 millimeters, and that's because the Ortho-K alignment zone typically begins at 8 millimeters. But what if we're fitting a larger diameter of lens? Could we use 10? Nikki, could you take us through this?
So we talked about calculating the sag previously when we talked on soft lenses. This is the same thing. So we have with Medmont two options, the details analysis, and this will give you up to data up to the moment you have the measurement data. So if you have data up to 9 or 10 millimeters, you will be able to use the detailed analysis function. If you need data or sagittal height beyond that, you will need to use the estimated height chord function. This is from 9 millimeters up. You can calculate sagittal height at 13, 14, any diameter you want. which is useful for fitting the contact lens you're using.
So this window, Nikki, take us through.
So this is the window you see when you use the details function. So there you have quick buttons to use the flat and the steep meridian. And then you have, besides that, to your right, the chord diameter that you can set at the distance you want. And then below you see the weighted average height, which is a sagittal height calculated based on the values of your measurements. You can do that on one measurement, or if you select multiple measurements, for example, if it's a challenging eye and you're not sure about your measurement, you can combine, select several measurements, and you can even have the average of that several measurements, so of the weighted average height. So that is based on the details function.
Okay, thank you. One of the questions that came up was that more a comment than a question, was that the Medmont tends to overestimate the eccentricity. This particular practitioner felt that the E value in Medmont was too high. And I thought it might be worth addressing that because it's a very good point. When you look at your analysis window here, your attribute window, this E value is measured over a chord of 9.35 millimeters. It's a fixed number, but you can adjust this value. So if your lens chord of bearing is less than 9 millimeters, like an Orthok lens, its alignment zone begins at 8 millimeters, we should not be using this value here because this is meant to describe the cornea as a whole, but as Nikki said, not the chord of bearing. So for a practitioner that's trying to build a lens that requires the E value at a specific chord, I would do what Nikki has shown us, go to the analysis and details window, set your chord value at the appropriate diameter, and then record the eccentricity from here. And I can tell you I've used this particular method of setting the chord at the specific chord measure of the lens, collected the eccentricity. And the Hong Kong Polytechnic study that was just published by Kiki Tan and Pauline Cho, I'm sure all of you know Pauline Cho's name in Orthok, they had a 95% first fit success using this E value over an 8 millimeter chord. So I find it hard to believe because there's numerous studies that show the lenses built from Medmont topographies are highly accurate with high first fit success. So if there was an overestimation, I wonder if it's related to using this value here, because the Orthok studies that have been coming out seem to suggest that Medmont is highly accurate. Last major topic was, what is the difference in corneal scleral shape around the circumference of the eye, nasal, temporal, superior, and inferior? And this early work by our group at Pacific University showed that OCT was able to give us a really good appreciation of these angles that form around the peripheral cornea at 10 millimeters, and they run right out to approximately 10 millimeters across the anterior chamber. So we get these angles that form where the cornea may not be described as a curved shape, but more so as a tangential shape. And this has been well documented. And I'm sure everybody has seen this slide that my colleague Pat Caroline put together. Now, what was interesting from this work was if you look at the angle differential at around a 10 millimeter chord into, a 15 millimeter chord into 10 millimeters, the eye has approximately 1.7 degrees of differential all the way around the clock. So if we land a lens close to 15 millimeters, the eye doesn't have a lot of scleral asymmetry. If you move out to a 20 millimeter chord of bearing and take that angle down to 15 millimeters, then you have approximately a 6.6 degree differential all the way around the clock. So what does this tell us? The closer we are to the limbus, the more symmetric the eye shape. The farther we are away from the limbus, the more asymmetric or toric the eye shape. The findings were generally that the nasal aspect had the flattest of the radiuses. Now, this work by Marcus Ritzman, who did this also at Pacific University, he's based in Europe, had come over to our school to do his master's thesis, and he did a really comprehensive understanding of the shape, the elevation, the angles of the eye at various chord diameters. And what he found was that, again, the closer we are to the limbus, the less asymmetry we have around the clock. The farther away we go away from the limbus, the more asymmetry we have around the clock. Generally, the inferior cornea had the greatest drop in elevation. So the inferior, sclera. And that might suggest why our lenses tend to want to fall temporal inferior, because that's where the elevation of the eye is so low in this direction here. And maybe assuming that a scleral lens may ideally center is not something that we can presume is likely for most eyes. Certainly it does happen, but for most eyes, we shouldn't expect that. So the highest elevations are nasal superior through this quadrant here, and that may be pushing the lens toward the lowest elevations, which tend to be temporal inferior. And then we also have lid force and gravity that plays a role as well. So what Medmont can do is it can understand the corneal sagittal depth and the scleral angle. And I think it does a very good job of that across the horizontal meridian. And that's been found by numerous studies, both in Europe and in North America. But I don't know if the Medmont topographer can give us a really good appreciation of the type of shape the scleral has. I think it gives us a good understanding of the predicted depth that we might need, but trying to use it to say, yes, we definitely have an asymmetric scleral shape or a symmetric scleral shape, I think that's asking a lot of the instrument. So I wanted to ask the panel, do you use, or how do you use the Medmont topographer related to scleral lenses? It of course is a corneal topographer, not a scleral topographer. Meta, could I begin with you? What are your thoughts on, do you use this tool in scleral practice, or is it not helpful?
I certainly do, and I use it as shown in the slide, that we measure the height in 10 millimeters, and then we can add up to the diameter where we know that this scleral lens we want to fit is landing. So this will give us a very, very good idea of which trial lens we will begin with, and very often it's very accurate.
Nikki, your thoughts? Do you use corneal topography? Do you use the Medmont for scleral lenses?
Yeah, as Meta said, it saves you a lot of time just to determine the first initial trial lens you'll put on the eye. It's very accurately, or at least very closely, determines the sagittal height, and then it's just very easy to determine the sagittal height of your first initial lens, and it saves you a lot of time of fitting trial lenses from your trial set, otherwise putting lenses on and seeing it's too deep, it's too shallow, and this way you save just an enormous amount of time.
It's nice to put one diagnostic lens on if possible, isn't it?
Yeah.
One of the questions was, will there be a webinar on how to use the contact lens fitting software? And it's likely that that's something that we'll be offering in the future. However, right now you can go to the Medmont website, and there are numerous videos related to fitting of conventional GPs, toric GPs, keratoconus, scleral lenses. So there are some great educational tools, all relatively short, that will address how you use this contact lens software. I wanted to, as my last question, I wanted to ask the panel, how do you use the contact lens software in Medmont? What types of fits do you use it for? What types of lenses or conditions? Meta, could I begin with you? Do you use the contact lens software?
Indeed, I use it a lot, and especially to design custom designed Orthok lenses, but also for almost any kind of lenses. It gives such good information on how much toricity we need to add into the back surface of the lens to achieve a good fit. So I think one of the things that I really like about topography is to understand the astigmatism in each eye, because it can be so different. But also, of course, for irregular corneas, and I just love the moment where we can like design the lens in the software, see the fluorescein pattern, and then actually see the lens on eye after it's made, and see that these images are actually identical.
Nikki, your thoughts?
Same as Meta. So one of the great things about the software as well, it's even independent of any lab. There is you can have a 3 curve, a 4 curve, 5 or 6 curve even. You choose the lens you want. You can design it to the diameter you want. You get a quite accurate fluorescein image from it, and certainly from those challenging eyes, it can save you a lot of time in trial fitting just by playing with the software and trying to find a good fit up front with the software before placing any lens on the eye.
Oh, I think such great points. Isn't it nice to fit a lens in a virtual world before we take a trial lens out of the case, clean it, take all that time to make sure it's going to go on eye and be wettable, then place it on, find it's completely off in base curve or diameter, then take that lens off, clean another lens. It's not very efficient, and being able to model the fluorescein pattern before we place that lens on helps us to be so much more efficient. I love the contact lens software. It's my favorite part of using the Medmont. Everybody, thank you very much for attending. We'd encourage you to hang in there just for another second, and we'd like to do this brief poll to kind of have a better understanding of your thoughts related to a few topics, and that will also give you an understanding, because you'll see how do your colleagues respond. Chris, do you want to take it from here, and Jill, do you want to bring up the polling questions?
Thanks, Randy. Again, the first polling question is, are you considering incorporating specialty lenses and topography into your practice? Well, very interesting. 88% of you, I'm sure, as I see a lot of very familiar names here as well, too, I see that some of you have already incorporated. And I'd be interested to maybe get some feedback as to the why we see the no's as well, too. So please feel free to send us your information, or you can send it to info@medmont.com. I'd be very interested to see your viewpoints. Jill, do you mind going to the next question, please? What are some of the biggest challenges you're facing when it comes to starting a specialty contact lens practice in your particular part of the world? Wow, interesting results. I can tell you that a little bit of a push here, but I can tell you that with this particular webinar that we're doing, this series of webinars that we're doing, is that a price point is going to be quite good. We're doing I guess given the times that we're dealing with as well too, and we understand a lot of practices have gone through some difficult times, I highly recommend that you download the distributor information and reach out to your distributor and get pricing on this. Another thing too is I guess when I see the 33%, I really look at that and say that obviously there's some more things that we need to do as far as training is concerned. And as I say, this is a continuing education, so we'll definitely be doing some more education series based on your questions as well too. I think the format was good, and I sincerely appreciate all the questions as well too. Proper training, again, obviously we need to definitely look at that and incorporating things as well too. And as I also suggest that you do is you reach out to your distributors as well too and get a virtual demo as well. Thank you very much for your input for that. Do you mind throwing up the other polling question there, Jill, if you don't mind? Wow. That's great to see for the 79%. For the 21%, the reason that I put the dues report in there is because the dues report, part of the protocol that they've suggested is that you use a non-invasive tier method for determining, but for evaluating dry eye. I highly recommend, and as I say, there is a dry eye function within the Medmont Topographer, and it's a very valuable tool in assessing or helping to assess a dry eye patient, kind of one of the first steps. It's a good tool, and it's a highly recommended tool as well too. As I say, it's a lot more accurate than what you're going to be getting from putting fluorescein into the patient's eye and doing that way. Sincerely appreciate all your time. Randy, I can't say thank you enough to yourself. I can't say thank you enough to Meta and to Nikki. It's been a phenomenal experience for myself, and I hope it was a great experience for a lot of our listeners as well too. As I say, this is not the end. This is just the beginning, and we look forward to doing another webinar with all of you as well. Again, thanks again to the panel.
Thanks, everyone.
Thank you. Bye-bye.
Bye.
Take care, guys. Bye-bye.